I'm Dr. Maurtua, staff anesthesiologist at the Cleveland Clinic, and today we're going to talk about the poster presentation, Post-Anesthesia Care Unit Crisis Preparedness in situ medical simulation. Our post-anesthesia care unit in main campus consists of 52 beds. This unit presents several challenges to our residents. First, environment and setup is different to the one that they encounter in the operating rooms. Second, patients arriving to this unit may have a diverse complexity of medical problems in addition to be in their immediate postoperative period. Third, the medical equipment is located in carts and locations that our residents might not be familiar with. Fourth, our PACU nurses play an essential role in patient care. Therefore, effective communication and teamwork is of the essence. Fifth, awake patients require a different approach in the crisis compared to patients undergoing general anesthesia. And sixth, the likelihood to encounter a critical situation is much higher due to the amount of patients admitted in this unit daily. Our goals are mainly to review crisis resource management, specific points, calling for help early, communicate effectively, and mobilize all available resources, among others. To review a common clinical scenario, such as hypoxemia, early diagnosis, differential diagnosis, and progression of treatment. To review pulses electrical activity algorithm, differential diagnosis, and treatment. This is an in situ simulation educational activity that is scheduled to occur the first Tuesday of every month at 9 a.m. The Center for Medical Simulation pre-briefing script is used. In addition, we highlight the mannequin's features, safety rules, Confederate presence, and the correct use of the defibrillator since we use our PACU defibrillator. The clinical scenario is based on a hypoxemic patient whose fast clinical deterioration ends in PEA. Once the activity is completed, a debriefing takes place in a separate location to decrease participants' stress. Key points in the medical response are highlighted, including timely administration of drugs and interventions, application of CRM, guidelines, differential diagnosis to consider, and the relevance of effective chest compressions. Assessment and feedback. We developed a 10-point assessment tool to help us determine the improvements that should be considered by our trainees. Our feedback is provided after the completion of the clinical scenario through a debriefing. Trainees' assessment continues throughout the residence rotation by the instructors and staff assigned in PACU. Our residents' verbal feedback in this activity has been extremely positive, not only highlighting the impact and importance of CRM application in real emergencies, but also addressing our trainees' perception of self-efficiency during a crisis in an environment that is not too familiar to them. Thank you to all the healthcare professionals that made this project possible.